Hello, everyone. Good morning, good afternoon, or good evening, depending on where you are logging in from. Welcome to today's webinar, Evaluation and Management of Postpartum Hemorrhage. I'm Ravi Sarode, and I'm the Chief of Pathology and Director of Division of Transfusion Medicine and Hemostasis at UT Southwestern Medical Center in Dallas. I also serve on the board of the Foundation for Women and Girls with Blood Disorders, and I will be moderating today's webinar. I can't advance the slides. Okay, there we go. The Foundation for Women and Girls with Blood Disorders mission is to ensure that all women and girls with blood disorders are correctly diagnosed, optimally treated, and managed at every stage of their lives. To this end, we aim to provide education to healthcare providers on the medical consequences and unique issues for women and girls with blood disorders. We have outstanding faculty today. Today's presenters are Dr. Chad Grotegut and Dr. Cathleen Peterson-Layne. Dr. Grotegut is an associate professor of obstetrics and gynecology and a maternal fetal medicine specialist at Duke University School of Medicine. Dr. Peterson-Layne is an endowed professor of anesthesiology and chief of the Division of Obstetric Anesthesiology at the University of Nebraska Medical Center. The activity medical director for today's webinar is Dr. Andy James from Duke University. The planning committee for today's presentation include our faculty and Dr. Barbara Conkle from University of Washington and James Munn from the University of Michigan. In accordance with Creighton University Health Sciences Continuing Education Policy, the faculty and planning committee for today's webinar have disclosed any significant financial interest or other relationship of interest related to the topics that will be discussed during this program. Such disclosures allow you to better evaluate the objectivity of information presented in this lecture. You may learn more about this at the Foundation's website, fwgbd.org. As usual, there are housekeeping issues. So to ensure that the best sound quality during the webinar, all attendees will be muted. However, you will have the opportunity to participate in a question and answer session with the faculty at the end of the webinar. You may submit your questions during or after the presentation via a chat box in your GoToWebinar control panel on the right-hand side of your screen. And we will address them during Q&A session at the end of today's presentation. This learning activity is offered through Creighton University's Health Sciences Continuing Education, which has been accredited to offer 1 hour credit for physicians and 1 hour contact hour for nursing professionals. Now to begin, we would like to take a quick poll to see how many other people are joining with you on this particular webinar. So please take a moment to answer the poll question on your screen. And let us know how many people are watching this webinar with you on your computer. Please go ahead and answer. Okay, it seems that most of you voted. So let's move on to the next slide. So the following are the learning objectives for today's webinar. For those who wish to refer to these later, we are recording the program and it will be archived on our website. Now I would like to introduce our first speaker, Dr. Chad Grotegut. Chad.
Well, good morning, and thank you so much for joining us for this session. I'd also like to thank the Foundation for the invitation to be here. And with that, let's just jump right on in. So primary postpartum hemorrhage refers to excessive bleeding within the first 24 hours of delivery, while the term secondary postpartum hemorrhage refers to hemorrhage that is delayed and occurs between 24 hours and 12 weeks from delivery. Postpartum hemorrhage has classically been defined as blood loss greater than 500 milliliters following a vaginal delivery and greater than 1,000 milliliters following a cesarean delivery, but more recent definitions focus on the amount of blood loss regardless of mode of delivery. To that end, the Royal College classifies postpartum hemorrhage as minor when the blood loss is between 500 and 1,000 mils, and major when the amount of blood loss is greater than 1,000 milliliters. Major postpartum hemorrhage is then subdivided into moderate and severe. In 2014, an international expert panel convened that included members of this foundation and settled on a definition for postpartum hemorrhage that included, quote, active bleeding greater than 1,000 milliliters within 24 hours following birth that continues despite the use of initial measures, including first-line uterotonic agents and uterine massage. In the recent updated ACOG practice bulletin, ACOG defines postpartum hemorrhage as cumulative blood loss greater than or equal to 1,000 milliliters or blood loss accompanied by signs or symptoms of hypovolemia within 24 hours after the birth process. The incidence of postpartum hemorrhage reported in the literature varies widely depending on the criteria used to define the disorder. US data suggests that the incidence is 2 to 3% of all deliveries, and range most often quoted in the literature is 1 to 5%. Using data based on hospital discharge diagnostic codes within the nationwide inpatient sample, Bill Callahan and his team at the CDC demonstrate that the incidence of postpartum hemorrhage in the United States has increased 26% from 2.3% of deliveries in 1994 to 2.9% of deliveries in 2006. This rise in the rate of postpartum hemorrhage was driven by uterine atony, and interestingly, the increase was not attributable to changes in mode of delivery, variations in maternal age, rates of multiple gestation, or medical complications that occurred over the time period. Postpartum hemorrhage due to other causes than atony did not change over the study time period. Data from the CDC also demonstrate that over a 22-year period from 1993 to 2014, the rate of severe postpartum hemorrhage or postpartum hemorrhage that required either a blood transfusion, as we see in the orange line, or postpartum hemorrhage that required an obstetric surgical procedure to control the hemorrhage has risen significantly, resulting in a 4 to 5-fold increase in both outcomes of severe postpartum hemorrhage. So uterine atony remains the most common cause of postpartum hemorrhage, representing approximately 80% of cases. Other causes of postpartum hemorrhage include lacerations such as cervical or vaginal, extensions of the hysterotomy incision at the time of cesarean, and though rare, uterine rupture. In addition, retained products of conception, placenta accreta spectrum, and coagulopathy all can lead to postpartum hemorrhage. So as uterine atony represents the most common diagnosis, we will primarily focus on the management of postpartum hemorrhage due to uterine atony in today's talk. So in order to better understand the pathophysiology of uterine atony, we need to be reminded of the blood supply to the endometrium and the non-pregnant uterus. The spiral arteries are terminal branches of the uterine artery and supply the endometrium. Furthermore, bleeding that occurs during menses originates from these vessels. During implantation of the developing embryo, the spiral arterioles are remodeled into large diameter vessels called uteroplacental arteries, or what I refer to as uterine placental pipes with our trainees. that are remodeled and now lack a thick muscle wall and are now unresponsive to vasoconstrictive agents. These changes in these vessels are important to provide optimal maternal blood flow to the placenta and the developing fetus during pregnancy. Following delivery and separation of the placenta from the uterine wall, the uterus must contract to close off the uteroplacental arteries. Uterine atony is then characterized by inadequate uterine contraction following delivery, such that these vessels remain open and bleeding ensues. The exact mechanism that primarily contributes to the etiology and pathogenesis of uterine atony is not known, but clearly failure of the uterus to adequately contract is central. In addition, there are well-described risk factors for uterine atony, but not all women will present with risk factors. Risk factors for uterine atony include prolonged labor, prolonged oxytocin augmentation, and high doses of oxytocin received during labor. In addition, conditions that lead to overdistension of the uterus, such as macrosomia, multiple gestation, and polyhydramnios, as well as magnesium therapy, chorioamnionitis, and general anesthesia can all affect the uterus's ability to adequately contract following delivery. So let's get back to Bill Callahan's data. The overall rate of postpartum hemorrhage is affected by mode of delivery, but induction of labor is an important contributor to rising and higher rates of uterine atony. Among women delivering by C-section, those who were induced had twice the rate of uterine atony compared to those who were not induced. So how much potential blood loss are we talking about at delivery? Remember back, there's an estimated 50% increase in maternal blood volume with pregnancy. With that, we see a 50% increase in maternal cardiac output with advancing gestation, typically peaking at 7.5 liters per minute near term in a normal weight woman. Of the 7.5 liters per minute in cardiac output near term, approximately 20% of this goes to the uterus, and of that, approximately 80% goes to the placental bed, resulting in approximately 1.2 liters per minute of blood volume to the placental bed. You can now imagine that following delivery of the placenta, we have the potential for significant hemorrhage if the uterus does not adequately contract around those wide open uteroplacental arteries. So it's back to Netter. The uterine artery is a branch of the anterior division of the internal iliac artery. The uterine artery then enters the uterus at the level of the internal cervical os and then branches superiorly and inferiorly along the lateral aspect of the uterine fundus. These branches then enter the myometrium on their way to the endometrial lining or the placenta. During labor, the uterine contraction phenotype is characterized by phasic contractions. Immediately following delivery, there is a transition in contractant phenotype from this phasic pattern to a tonic or tetanic phenotype manifested by a constant uterine contraction and elevated resting tone. The phasic contraction pattern that is seen during labor allows for placental gas exchange and therefore oxygen delivery to the fetus and removal of carbon dioxide between contractions. The tonic or tetanic phenotype seen in the immediate postpartum state allows for the closure of the uteroplacental arteries, thereby preventing postpartum hemorrhage. The molecular mechanisms that regulate this transition from phasic to tonic contractions is not known, but certainly failure of the tetanic contractions immediately postpartum results in uterine atony and increases the risk for postpartum hemorrhage. So this figure illustrates what we just discussed. Uterine blood flow into and out of the placenta occurs only between contractions. With a uterine contraction, the fetus relies on oxygen stores within the placenta as oxygen delivering into the placenta is impeded as the intramyometrial pressure is greater than the mean arterial pressure of the uteroplacental arteries during a contraction, causing those to close off. This concept is important following delivery and separation of the placenta. So following delivery, the contraction phenotype again transitions from this phasic pattern seen in labor to a tonic pattern. This constant contraction pattern facilitates closure of the uteroplacental arteries, preventing hemorrhage. So again, the tonic contraction pattern allows for closure of the uteroplacental arteries that were supplying the placental bed. Prolonged tetanic contractions ensure that the vessels remain closed during the immediate postpartum period. In cases of uterine atony, there's failure of the uterus to produce a tonic contractile phenotype. The uteroplacental arteries remain open, resulting in uterine hemorrhage at rates up to our previously calculated 1.2 liters per minute. So what tools do we have to prevent uterine atony? Many of the previously described risk factors are unavoidable. Furthermore, uterine atony can occur without an identifiable risk factor. So as such, all women receive a bolus of oxytocin immediately following delivery. Oxytocin bolusing is the mainstay of prevention of postpartum hemorrhage due to uterine atony. The dosing given is approximately 50 to 300-fold greater than the oxytocin dosing that's given during augmentation of labor. This helps facilitate the transition from that phasic to tonic uterine contraction pattern. But despite this, not all women respond, and further treatment is required for uterine atony. So at the time of presentation with uterine atony, it's extremely important that we first make the diagnosis, which can be highly subjective. But with experience, back when I was on my first day on L&D as an intern, my supervising physician, Bill Herbert, told me, just pointed out, that's too much. And that's what the experience provides. Tools have also been developed to better estimate and quantitate blood loss at delivery and include graduated containers and drapes, visual aids that provide examples of quantified losses, differences in weight between the wet and dry objects such as sponges and drapes, and newer technologies that take optical wavelength readings. So next, optimal outcomes are achieved with early intervention, helping to avoid shock and DIC. And finally, we need to quickly rule out lacerations and retain products as etiologies, and then focus on initiating treatment for atony. For uterine atony, medical management remains the most important first-line tool for treatment. Medical management includes the use of various uterotonic agents, each targeting different receptor or signaling pathways within the myometrium. Along with medical management includes consideration for blood component therapy, and then when medical management is failing, a stepwise transition to surgical management is then needed. So oxytocin remains the most important agent for the treatment of uterine atony and should remain the first-line agent even when atony presents despite the use of prophylactic oxytocin following delivery. So oxytocin has a really interesting history. The first published clinical use of an oxytocin product was by Blair Bell in 1909. He was a British obstetrician who utilized posterior pituitary extract and left us with a quote in his paper that said, quote, "There is no doubt, I think, that any of these properties is sufficient to secure a permanent place in therapeutics for this much neglected portion of our anatomy." He appreciated that it should rarely be given prior to delivery of the fetus due to concerns for tetanic responses, and demonstrated in figures in this paper the effect of pituitary extract on uterine contractility as well as on blood pressure. Then in the 1940s and 50s, you'll have to excuse my French, but de Vigneault, I guess, isolated pure oxytocin from posterior pituitary extract. He then proposed the amino acid sequence and structure for oxytocin, and then was able to produce synthetic product which was indistinguishable from the natural hormone. He won the Nobel Prize for this discovery, and it was also the first peptide hormone to have its amino acid sequence determined. Once postpartum hemorrhage due to uterine atony is recognized, oxytocin should remain the first-line agent, and there are no absolute contraindications to its use. There are various regimens used out there, but most L&D units use 40 units in a liter and then titrate the infusion to achieve and maintain contractility. In instances where there is no IV access, 10 units of undiluted oxytocin can be given IM, but direct IV infusion of undiluted boluses should be avoided or only performed on extremely experienced hands. So next, let's move on to the ergots. The ergots are a product of fungi that can activate adrenergic receptor systems. They've been found to induce strong uterine contractions and raise blood pressure. Dale was the first to publish on their effects on uterine contractility in 1906. Ergots are difficult to store. They require dark refrigeration and sealed from high humidity and temperature. Methyl-ergonovine is the most commonly used ergot. It increases muscle tone with superimposed fast rhythmic contractions of the myometrium, and also elicits tetanic contractions for several hours. It should not be given IV and should be avoided in women with severe hypertension. It has a quick onset of action, and if the first dose is ineffective, move on to the next agent. The next class of agents are the prostaglandins. The prostaglandins work through the prostaglandin receptor system, which is also a G protein coupled receptor similar to the oxytocin receptor. Hemabate is prostaglandin F2 alpha, is given as a 250 microgram IM injection and can be repeated every 15 to 90 minutes up to 8 doses. Side effects include tachycardia, fever, nausea, vomiting, and diarrhea, and the drug should be avoided in women with severe asthma. Next, misoprostol is also a prostaglandin, but of a different class. It's of the E1 class. It's very stable at room temperature, is inexpensive, but its optimal dose and route of delivery in obstetrics is still unclear. Sublingual and oral dosings have a rapid onset and high peaks, but shorter effect time and higher risk for side effects, while rectal dosing has a slower onset, but a longer duration of action. Our unit uses rectal misoprostol to help maintain prolonged contractility in the setting of atony once other agents have achieved adequate contractility in the acute setting. Fever is common with misoprostol, but there are no contraindications on its use with hypertension and asthma, as we saw with the other two medications we just discussed. Carbetocin is a long-acting oxytocin analog that is commonly used in Europe and Canada, but is not currently available in the United States. It is used primarily for the prevention of postpartum hemorrhage following cesarean delivery. The drug has been modified to have a longer serum half-life, which provides a longer duration of action. So this is a copy of a bedside cognitive aid that we use on our labor and delivery unit at Duke. It's a quick reference guide for providers and nurses listing the various dosing regimens and contraindications for the most commonly used uterotonic agents. When medical management is not successful, moving on to surgical approaches is often needed. This includes methods to occlude the uterine cavity, which include Bakary or Foley balloon placement, uterine packing, or use of a B-Lynch or other external uterine compression device. Next, methods to diminish blood supply to the uterus may need to be employed such as uterine artery ligation, uterovarian vessel occlusion, and uterine artery embolization. Lastly, internal iliac artery ligation or hysterectomy may be required for definitive treatment. So here's a picture of a balloon tamponade system. The balloon is inflated inside the uterine cavity to tamponade those open uteroplacental arteries that we talked about earlier. The B-Lynch suture is a suture brace that occludes the uterine cavity by external compression. So at our institution, in the setting of continued uterine atony despite medical management, the decision to proceed with placing uterine compression sutures or inserting a uterine balloon is largely determined by mode of delivery, where we typically will place a B-Lynch suture brace at the time of cesarean delivery, but insert a uterine balloon at the time of a vaginal delivery. In terms of lacerations, for cervical, vaginal, or uterine incision lacerations, they need to be identified early on in the presentation and repaired quickly. Similarly, retained products of conception should be recognized early and treatment initiated. Careful visualization of the placenta can assist in diagnosis. Cases may require DNC, and certainly consider the possibility of an adherent placenta due to placenta accreta when this occurs. So in summary, regarding the first half of today's talk, preparation and anticipation, as well as early diagnosis, are important in ensuring optimal outcomes with postpartum hemorrhage. Quickly rule out lacerations and retained products, and then move toward treating uterine atony when it's present. Medical management is the mainstay of treatment for uterine atony, but surgical options may be required when medical management fails. There's still numerous research gaps in this field, including identifying the optimal drug combination or development of personalized uterotonic approaches for the treatment of atony. And with that, I'd like to turn the podium over to Cathleen, who will provide us with the obstetric anesthesiologist perspective.
Kathleen, I believe you have yourself muted.
I am. Thank you so much. I was just saying thank you for this opportunity and appreciate the invitation from the foundation. And it's a great pleasure to be able to collaborate with my long-term colleague, Dr. Grotegut, who was a colleague of mine for many years while I was at Duke University. I'm going to give what might be to many listening today a unique perspective of an anesthesiologist and what our role is. There we are. I find it's very important. I've emphasized sort of some points that Chad just emphasized, that it's important for us to identify risk factors for patients on an individualized basis so that we can anticipate and prepare for hemorrhage should it happen. In addition to that, is even in patients without risk factors, they can still occur. So we need to then be on our guard to recognize it and to act without hesitation. We often think of the relationship between obstetricians and anesthesiologists, certainly in the operating room setting, as having a divider between us. Whereas this picture, I actually think is more to show that we aren't divided. We're actually surrounding the patient with all of our care and all of our skill. And this surrounding the patient extends beyond the operating room for preparing our patients for delivery, including consultation with our hematologists, our pathologists, or transfusion medicine specialists, even prior to patients coming for delivery, at least for those who have risk factors, and involving them in helping us to be prepared and to even act in the care. So it's surrounding that our patients, the care we provide needs to be coordinated and complementary in nature. We don't need 5 obstetricians in the room. We need multiple skill sets in order to take care of the patient. And certainly the obstetrician, as Chad has well described, is very busy deciding what the cause of hemorrhage is, and oftentimes physically intervening to control that bleeding. So we have coordination at both the patient level and then also at the systems level, because that communication needs to go beyond. It needs to include what resources are available to the care team and have it distributed, have it applied in a coordinated way. Chad already mentioned that we want to determine how much blood is lost. And it's very important before you just, do I have a hemorrhage or not? And there are a couple of techniques that are used. Up until recently, the only technique we used was estimated blood loss, and that is, like you said, that's too much, or worse yet, is not identifying that that's too much. That's the real concern with estimated blood loss. And another technique that's becoming more popular is the quantitative blood loss, that is actually measuring how much blood is lost. With the estimated blood loss, again, it's a visual technique, and there's several studies showing that it can vary in either direction. Most of us underestimate, however, the amount of blood that's actually lost from a patient. This is an example too of some visual aids that some folks use and have mounted just to give an idea of how much, be able to compare in real time with a lap pad with blood on it. How much does that, equate to? Is it 25 mils or is that 250 mils? But again, it's a flawed system in that we often underestimate how much is actually lost. The quantitative blood loss, which is being promoted by AWON, the Association of Women's Health Obstetric and Neonatology Nurses Organization, is to actually measure in a quantitative sense. This shows you graduated cylinders or graduated drapes that are commonly used in vaginal deliveries to capture most of the blood loss. In addition to this, lap pads or other materials used that may have blood on them are actually weighed on a scale. This is although it uses technology, it can be done as a relatively low-tech way, in that the scale that we use at our institution is the same scale that we use for weighing our babies. Now, not the same scale itself, but the same technology, the same caliber. So it's a relatively inexpensive way of doing it. And then they always often have drapes to collect the blood just for cleanliness, and just adding the graduated markings on it to help to quantitate it. Again, it's not perfect because we're never going to collect every drop of blood that's lost, but it gives us a better idea than just simply eyeballing it. There's also, as Chad mentioned, some technology that's available now. This is actually a tablet over here, and then you see the provider who's holding up a saturated lap in front of this tablet, and the technology is such that it can then give a measure, an estimate of how much blood is in that based on the refraction pattern. So besides measuring the blood, we have the best monitor we have is actually the patient we have itself. So in normal situation, we have normal sinus rhythm, normal blood pressure, normal heart rate. I don't have values up here because there's no one number that fits every woman. And the situation, the delivery mode, the amount of pain that she's in, there's lots that can, whether she has preeclampsia, a lot of things can go into this. So where that patient's baseline blood pressure and heart rate are, and then the EKG rhythm. With significant blood loss, you then would expect to see a decrease in the heart rate, a decrease in the blood pressure, and a reflexive increase in heart rate. Because many of our moms are young, healthy women, our cardiovascular system is able to adapt. So these findings may not be that sensitive, but that's sensitive to the amount of blood loss. In other words, they can compensate pretty well, and you may not see these signs early. Another sign you wanted to look for too is mental status. How is mom doing? Is another sign. This is particularly important. This changes in vital signs and mental status are important, especially if the EBL and the QBL are saying not much blood loss. Then you need to really rethink that, and also know too that these vital sign changes can occur from other things other than hemorrhage. Today we're focusing on hemorrhage and how to approach that, but other things happen to moms too that require other interventions besides transfusion. So why do we worry about such blood loss? Well, we need adequate volume in the cardiovascular system for organ perfusion, which includes carrying oxygen to these tissues, as well as maintaining adequate factors for coagulation and the metabolic balance. Metabolic balance, the most common metabolic disorder that happens is metabolic acidosis from the lack of oxygen being carried to the tissues and to the muscles and all, and then resulting in anaerobic metabolism and the production of lactate. So some things that, well, all this is going on, the blood's being lost. As an anesthesiologist, I'm thinking about more than just what the EBL is or what the QBL is and what, do I need to transfuse or not? I'm also thinking, do I need to intubate this patient? Is this going to be safe for her to be maintained? I say that because most of our patients, when we deliver, are under, it's cesarean delivery under spinal epidural, and sometimes we have an epidural in for managing a vaginal delivery that then can be converted if the obstetrician needs to do more invasive management. But there comes a time when you have to ask, would this patient be safer with their airway protected? Would I be able to provide oxygen and ventilate better if I had an airway in place and not be dependent on her ability to do that on her own? And hemodynamic stability. I can usually have control a little bit better if the patient's under general anesthetic. This also, part of this equation too, comes down to the maternal tolerance of what's going on. Certainly if they're moving to more invasive procedures or even a hysterectomy, then it may be necessary to convert to general anesthetic for tolerance of that. I mentioned tolerance of resuscitation. Once you get to a large volume resuscitation, you can end up with TACO, the transfusion-associated cardiac overload, and you might be volume overload, and that can sometimes be poorly tolerated, especially when it comes to from the ventilation point of view. This is because the edema and all that can develop as well. And if that does develop, just as you see peripheral edema, you can also see edema in the airway, and which can make it more challenging to intubate if that decision is delayed. Another decision to be made is about invasive monitors and additional access. Arterial line allows us to monitor the blood pressure, essentially every beat of the heart, so we can be even more precise as far as our interventions and more timely in our interventions and prevent any delays from that. It also allows us, an arterial line is very convenient for drawing blood, certainly without sticking the patient each time. Prefer my drug of the A line over the central venous catheter because the central venous catheter is a large bore IV that I want to be putting fluids, blood products, medications forward flowing rather than pulling them back. So along these lines of the anesthetic considerations, the access is a big issue. Having a large IV, we usually start off with an 18 gauge or so, sometimes 16 gauge IV. This is the type of catheter I put in when I have a patient with a massive hemorrhage. It is a 9 French catheter. And you see it has a couple different ports that I can put in, so I can put in different medications along with the blood products would be the way. It also allows for a PA catheter, but there would be no role for that in a healthy patient when the concern is volume. Monitoring, I mentioned the arterial line for close blood pressure monitoring. We also have available non-invasive cardiac output monitors that can be used as well, and that's helpful just to assess the resuscitation. Echo is also becoming very popular in obstetric anesthesiology practice, especially the focus exam, which essentially can be done in about 5 different points. Really a kind of a quick and dirty. Is the heart pumping? Is the heart full or empty? And then, and also important for in obstetrics, the right the right ventricular contractility, since that can be impaired with and right RV dilated in situations such as amniotic fluid embolus or pulmonary embolus. Again, not the topic of today's talk, but important that could also result in hemodynamic changes. And then, of course, we're also in the process of sending labs, monitoring the results of those labs to then make decisions relative to the resuscitation. So there's a lot going on behind that curtain, just as part of the whole coordinated team of care. So part of being doing all this is to be prepared. The World Health Organization and ACOG, among others, are strongly suggesting that every site that delivers, where there's deliveries, has a hemorrhage protocol or a hemorrhage bundle. One of the ways that we've done this at Nebraska is to have a cart that has all of our supplies organized. And you'll see the labels on the doors to help people to identify the location of key items. This is the supplies for placing a central venous catheter, for the supplies needed for placing an arterial line and monitoring it, as well as other resuscitative fluids and some key drugs. A key part of this is the fact that it is on wheels. Because it's on wheels, and I know Duke has a similar one as well, we can take this anywhere. We can take it to any of our operating rooms. We can also take it to our postpartum rooms. It allows us to have everything in one place as opposed to duplicating items and to have it at the ready access. It also gives a nice work surface, so as you prepare a lab sample and all that, that's always a good plus to have. The other thing too, it's good to have the supplies organized. You also have to have your staff organized, and then have a system that allows for quick all hands on deck. Whether it be, and systems vary as far as how this looks. Systems vary as far as what they have on their cart and where their cart's located. Needs to be specific to your particular hospital as to what works best. There's all hands on deck. The optimal is to have a one call that then goes to, say, like the main operator, who then is able to send out a page or some sort of notification to everyone in a coordinated, systematic way that is needed to manage, to be part of that coordinated care team. This is another supply that should be on every labor and delivery unit, not necessarily the specific level 1, but a rapid infuser. And this is just one example of a type of rapid infusers. There are others, there's some that you can actually infuse whatever you put in there, so it's red cells or crystalloid or whatever, at about 500 mils per minute. So this can be very, very valuable because as Dr. Grotegut said, the blood loss in an obstetric hemorrhage can be very brisk, hence replacement needs to be brisk as well. And that's why you need to have the large bore IV, such as the 9 French central venous catheter, to be able to accommodate the flow. This is actually a picture from one of our nurses at Duke who's actually using the obstetric hemorrhage kit. So you'll see here this plastic kit that is a bundle for single use and then replenished. It contains many of the items that are needed for management of a hemorrhage. It's with respect to the labs that are sent, and you'll see there that she's filling lab tubes, and in this system they have to send labs to 3 different locations. So they are color coded to make that, again, this is what works in that system. On that information, on those papers too, it prompts for all the information that's needed by the lab to allow them to process the sample. It alerts them that it is for an obstetric hemorrhage, so they know to drop everything else and to process these samples. It also, in this kit, are other laminated cards that are color coded that are defining out the different roles that are needed. In addition to having an obstetrician and having an anesthesiologist, you also need nurses that do different functions. She's actually working as our scribe and making sure all the lab values are going to be recorded. We have someone who acts as a runner, and then of course you need nurses to act as, the circulating nurse, and every system can define roles based on what their needs are and what their resources are in their system. There we are. And this slide, just to illustrate that you just cannot cut corners in this. There's you have to be prepared. There's no room for heroes. There's no room for, you have to develop and teach a coordinated approach to the hemorrhage, and it has to allow for everyone to be prepared in order to provide the best for the patient. The other thing I would say about this too is that I mentioned anesthesiologists. I realize that not all systems have 24/7, and certainly not OB anesthesia trained people. It's important to get people on board as quickly as possible. So if your anesthesia provider is not readily available, they need to be notified at the first hint that there might be a hemorrhage. You have concern of hemorrhage, to be able to step in and assist. But even if the provider is not readily available in-house, then they need to be notified so they can get there. And it's better to be notified and then not needed than to have concern about any delay. Actually, there's reports with the maternal, the triennial report out of the UK, that the cases that are preventable are due to denial that bleeding is happening, and delay in care. And that's what these systems are intended to do, is to coordinate that to prevent those from being the causes for untoward events. So what labs do we get, and how often do we get them? Well, we need multiple sets of information in order to take care of mom. Certainly we need counts of the cells that are being lost. So hemoglobin, hematocrit, platelet count, fibrinogen is also important, and we want to get that on a regular basis, since that's what we need all in order to carry the oxygen and also to form a clot. Coagulation studies clearly important for making sure that it's adequate for coagulation. Some people use PT, PTT, thrombelapsography. That's a whole nother discussion as far as the pros and cons of those. But probably other folks on this webinar could actually, in the audience, could speak better to than myself even. We also routinely measure blood gas. The pH is important, as I mentioned, because you can get a metabolic acidosis, which can affect the function of proteins, including coagulation proteins. Oxygenation, important. CO2 is a measure of ventilation, and that can contribute also in a ventilator. You can contribute to the acidosis. And then lactate's important. It's just as a trending more than actual number, but it allows for the to trend and gives you a sense of your perfusion of tissues. There's some electrolyte anomalies that can occur as well that can also contribute to arrhythmias. The most common is hyperkalemia, and certainly with the transfusion of blood, you can contribute to that. And then hypocalcemia, also affected by blood transfusions because of the chelation by EDTA. And then glucose is often increased as well, but not usually to the point that it's a concern. But we measure glucose because the method of correcting potassium levels is to give insulin to drive the potassium into the cell, which in order to, when you do that, we also give some glucose. We just monitor the glucose more to make sure we're in a safe range as we do our medical management to treat the hyperkalemia. And you need to be ready for treating all this and during a hemorrhage. Lots of information to be coordinated and communicated because you have a lot of people doing lots of different things, and you have folks who are making decisions based on this information. So this is actually a spreadsheet that we use, and it allows for the documentation of all the values from all the different labs that are coming from different locations, and they're written in a way that allows for them to be documented in the order in which they're read back from the lab, if that's possible. I find that this paper grid to be helpful, even when labs are brought back a lot electronic, because an electronic record, depending on which one you use, it may not be organized in a way that's helpful to show you trends relative to each other. So just a thought, sometimes duplicating efforts might be worth it. So how do we replace the blood that's lost? There's some literature from the trauma arena about using a 1-to-1-to-1 of red cells, plasma, and platelets. It's really not real clear as far as what the optimal is as far as replacement for obstetric hemorrhage, but many of us have adopted this as a general rule of thumb, as opposed to back when I was training, you give six packed red blood cells before you even think about giving any FFP or platelets. And certainly we know better now that a more balanced technique to replacing what's been lost is preferred. The optimal way is lab driven, to be able to have it based on your values. But this would be for empiric. The target hemoglobin of about 7 milligrams per deciliter, all things being equal, this is for a healthy mom without cardiovascular disease, and a platelet count targeting to be greater than 50. Fibrinogen is important, and we know from some work, actually back in 2007, Dr. Charbet published that the decreased fibrinogen is an early predictor of the severity of obstetric hemorrhage. That is, if fibrinogen was less than 200 in the setting of ongoing obstetric hemorrhage, that was predictive of it getting more severe. Fibrinogen can be replaced by cryoprecipitate or fibrinogen concentrate. Again, knowing what's in your system and what's available and for ready access. And there are also some emerging protocols that use thrombolapsography to guide the replacement. Probably should have put this before. Most of you probably are aware that coagulation factors are increased during pregnancy, and fibrinogen is actually increased about 2 times. So a normal, more of my residence is that when it reports back on the computer, reports back a normal level, you have to take in consideration the fact that she's pregnant. So what's normal to my computer may not be normal on what I expect to be seen in this patient, and it may have concerns. But in general, women are hypercoagulable. So this has been a game changer. We don't have, it seems like in anesthesia, we haven't had many real game changers in the last, 10 years or so. This has been for OB anesthesia and for many of us, for those in OB. The results of the woman trial, that was an international double-blind placebo-controlled trial with tranexamic acid, which is antifibrinolytic. So once the clot is formed, it keeps it from breaking down. The trial included over 20,000 women and conducted at 193 hospitals in 21 countries. They gave TXA versus placebo within the first 3 hours of a postpartum hemorrhage. And what they were reporting is a reduced death due to bleeding, and very importantly, no change in thrombotic events or seizures, which were a real concern given the hypercoagulable state in pregnancy. So this is a real game changer, and now giving TXA. The other study that came out from Lancet soon after this actually is a meta-analysis, and it has over 40,000 women that reports has in that cohort 3,500 deaths, and 40% of those were from bleeding. The statements that they made is that immediate treatment improves survival by more than 70%. In other words, give the TXA, but give it early, because they also state too that survival benefit decreased by 10% for every 15 minutes of treatment delay up until the 3-hour mark. And after the 3-hour mark, there was no benefit of giving it. So if you think you have obstetric hemorrhage, ongoing bleeding, then TXA is encouraged. Well, what about cell salvage? Because actually, I'm just looking at the clock now. I apologize. I need to write this up. But cell salvage has actually been shown to be safe in obstetric hemorrhage. What we do is we can use it in vaginal or cesarean delivery. Is usually deliver the placenta, clear the amniotic fluid, flush with some saline, and then go ahead and collect with a different collection system into the cell salvage device that allows the cells to be washed and then given back. But it can be safely used. The concerns of amniotic fluid embolus occurring have been shown to not be a problem if the appropriate filters are used. So what does failure look like? Failure looks like slowing pulse. So you get patients tachycardic, and now their pulse goes down to being Brady. Not a good sign. Decreased pH, acidosis, hyperkalemia, hypocalcemia, hypoxia, hypercarbia. Those are all very ominous signs that you need to correct. For those of you who've taken ACLS, Advanced Cardiac Life Support, they talk about 5 H's and 5 T's and caused arrhythmias. Here we have 6 of those 10 right here. So I want to end on a positive note, because more often than not, we're successful. And this is our goal, is to have healthy mom, healthy baby, and to resuscitate, to identify, to not delay, and to successfully resuscitate. Thank you for this opportunity.
Ravi, I believe you have yourself muted.
Okay, thank you very much, Chad and Kathleen, for those outstanding presentations. And now we're open for question and answer. Those who want to type in their questions, please go ahead and do that. So in the meantime, Chad, if you don't mind, I'll ask you a simple question. Do you know any time during your intervention with PPH, do you get any involvement from interventional radiology or any other services?
It's a great question. We're at Duke, we're very lucky in that we have an outstanding interventional radiology group. But what I found in the setting of a profound hemorrhage due to uterine atony, we haven't been able to utilize their resources in the acute management because our patient hasn't been stable enough to get downstairs. We've utilized them for and the more chronic issues, chronic, slow bleeding, where someone is bleeding through, a pack is in place or a balloon tamponade is in place, and then over the course of 12 hours they're bleeding. We've utilized them in that setting. We've also utilized interventional radiology for more during surgical procedures where we feel like that there's been a vessel transected that we just can't get access to. So that's our experience with interventional radiology, but they're certainly an important component.
Next, Kathleen.
I was just going to add to that as far as interventional radiology. Another technique we're exploring for use too is the REBOA, which is a device used in trauma to actually obstruct the aorta, and that is something that sometimes you get to that point, and it doesn't require the same fluoro that interventional radiology demands.
Excellent. We have a question from the audience, Shweta Gupta. She's asking about, could you discuss PPH in women with bleeding disorder? How do you plan it? How do you get help from hematologist or transfusion medicine or coagulationist?
I'll take that. So if you're fortunate enough to have the patient identified ahead of time, which hopefully you are, then we actually see patients that I can speak to when I was in practice at Duke with Kat, is that the MSNs would refer them to OB anesthesia for a consult. And we would even have group meetings with our hematologists, with our transfusion medicine specialists, and have a plan as to what values, anticipate, making sure they're optimized prior to delivery, and having a plan of how we would contact people if we needed help at the time of, if things did go south and we needed to have some support, cognitive support then.
Great. And then as regards massive transfusion protocol, do you have the same protocol for trauma and OB, or do you have separate protocols?
I can take that. At Duke, we've recently modified the massive transfusion protocol for the hospital-wide, and where it's slightly different than what we see on obstetrics. On labor and delivery, the first round of release of products is 4 units of pack cells, 4 units of FFP, and a unit of cryo, where the remainder of the hospital for trauma or transplant, they don't release the cryo, they just release 4 units of pack cells and 4 units of FFP. Following that, our next round is 4 units of pack cells and 4 units of FFP. But then, as Kathleen had mentioned, our anesthesiologists start kind of a laboratory-based protocol, and utilizing labs that come back, rotem that comes back, will then start adjusting the transfusion.
So that's very interesting that you have cryo coming in the first shipment, because it takes around 30 minutes to thaw a dose of cryo. How you're able to get that?
You're right. And so when we call the massive transfusion protocol, what the blood bank will do is immediately release the pack cells, the FFP, and then they'll start thawing the first unit. As soon as the cryo is then thawed, then they'll bring that up to the labor and delivery floor, but they'll start the thawing process right away. Kathleen?
Yeah, at Nebraska, we have a single protocol, and we don't get cryo until the 3rd round. So it's what I've encouraged people to do is to order cryoprecipitate immediately. So get the massive transfusion protocol activated, but cryo in addition. And that's been our way, right? That's been sort of my Band-Aid way of not having an official OB hemorrhage protocol, but adapting it to OB. And I think that's what many systems may need to do, or at least, as you take the steps to build a protocol. I think it's easier to get one started and then spin off, as opposed to trying to develop two at the same time if you're at that stage. I'm still obligated to give a shout out to Dr. Evelyn Lockhart, who may be on this line in the audience, who is transfusion medicine specialist at Duke, who was the leader of developing the OB hemorrhage protocol.
I mean, you very nicely illustrated that fibrinogen is the key element for patients with OB hemorrhage, because less than 200 milligram, they continue to have bleed or ooze. And therefore, I think a cryoprecipitate should be used as soon as possible, or fibrinogen concentrate. Any of you have tried fibrinogen concentrates like Riastap or another fibrinogen concentrate that's now licensed from Octapharma? Either a Duke or okay.
I have. I used it for several, I think about 3 or 4 patients at Duke. It works great. What I like about it is you can just,
Right.
pop the cap, reconstitute, and go. And I personally think it would be a great resource for low resource areas.
Mm-hmm.
If that makes sense, and that because the shelf life, and you don't have to worry about the thaw. You don't have to worry about, it's has a pretty long shelf life and readily available. So that would be my recommendation.
I wish company that had done clinical trial to make it available to all other sites. Then we have one simple question about how about other factor concentrates like recombinant 7A or PCC? Have you had chance to use it or during massive hemorrhage?
Kat, do you want to take this or Kim?
Go for it, Kathleen.
Okay, I've used it a couple of times. I really, and I think the data's kind of mixed as far as for factor 7, which is what we had, initially, of course. It's tricky in that for it to work, you have to have normal pH. Well, by the time you're at that point, you probably have a metabolic acidosis. You need to have normal platelet number of function, and usually thrombocytopenic at the point that you're giving that interval line agent. Also, there's concerns as far as thrombus. I have not been in a position to use PCCs yet in OB. I guess we're at the point where, last resort, I would, but certainly I think that has some promise. We just haven't had the opportunity yet.
And then how about ROTEM or TAG? Do you have display in your OR suites, or how do you get information about that on timely fashion?
Kathleen drove that initiative at Duke, and we do now have ROTEM display on monitors in the operating room at Duke, and ROTEM is included in the labs that we send every 30 minutes during a hemorrhage protocol. And I think, and our anesthesia colleagues I think it's really been helpful for them to adjust their transfusion, either blood component therapy in response to the ROTEM, especially in the setting of hyperfibrinolysis, using TXA.
So what's your expected turnaround time to see the tracings once you send sample?
The tracings start populating as soon as they come up in real time in our system, and so as soon as they start running the sample, you can see the clot formation in real time. We certainly, I can't remember Kathleen, if you remember, is the entire process 30 minutes? So we don't get the full results back, but you can see the clot form in real time and determine whether it's breaking down.
Yeah, you send it to the lab, and it's a 5-minute process that they have to go through before they put onto the sample to get it to start running, and then you can actually get preliminary results, especially with FibTem, to know if you need more cryo or fibrinogen concentrate within 5 minutes. Mm-hmm. Certainly, there's some data out there about the 10-minute mark, and then fibrinolysis, it usually happens. You're talking, if you have significant, you're going to be able to see it within about 20 minutes or so of the sample, which is, so much better than the turnaround time for other labs. Mm-hmm. And especially the fact that you can make real-time assessments. And we use TAGA here in Nebraska, and we do have arranged for in the OR viewing of that as well. And also computers, on our mobile carts, we have computers that are displayed as well.
So one question is from the audience. Does general anesthesia increase the risk of bleeding with operative delivery?
Well, it's the concern is their inhalation agents do contribute to atony. So because sometimes the good thing we use it for at other times to uterine relaxation, but it can contribute. What we can do though is to minimize or even avoid inhalation agents. By using other, like say, IV agents instead. We typically use inhalation agents in urgent emergency situations, because it's a lot faster to turn a dial than to prepare medications for IV, but that can be done to decrease that risk.
I think with that, I would like to thank both the speakers and audience for participating in this wonderful webinar, because we are already 7 minutes over time. And thank you very much. You can access this webinar on our website if you want to go back and listen to it. Again, thank you very much, Chad and Kathleen. And
Thank you for having us.
Thank you for the opportunity.
Okay, bye-bye.